Helping Seniors Television, all about improving quality of life for seniors. If you're a senior, know a senior, or plan to be a senior, then this show is for you. It's all about helping you develop your own aging plan so you can age actively and with dignity. Helping Seniors Television from the Helping Seniors Network of information, education, and resources. Welcome to today's edition of Helping Seniors Television from the Helping Seniors Network. Whether you are caring for a senior, are a senior, or just plan to be one, we hope you'll enjoy today's program. Dr. Jason Garlington, fellowship-trained cornea specialist and glaucoma, cataract, and refractive surgeon with the Eye Institute, visits with Helping Seniors TV host and longtime senior advocate Joe Steckler. The topic in today's episode is glaucoma. Get ready to receive valuable insight into this topic.
Welcome to this edition of Helping Seniors. My panelist this afternoon is Dr. Jason Darlington of the Eye Institute. Welcome, Dr. Darlington.
Thanks for having me.
Oh, it's a pleasure to have you. It's a pleasure to have you because he's my eye surgeon. And we're going to talk, in the future, we're going to do a show about cataract surgery, but right now we're going to talk about glaucoma. Dr. Darlington is also very interested in this topic too. I think most all eye doctors are interested in glaucoma, aren't they, Dr. Darlington?
Yeah. Most eye doctors manage glaucoma, at least medical glaucoma in some regard.
Yeah, it's very, what exactly is glaucoma?
Glaucoma, by definition, is the slow degradation of the optic nerve. So the optic nerve will sustain damage over time, and as that happens, slowly peripheral vision is lost. And unfortunately, glaucoma damage and optic nerve damage is permanent. And so any vision loss that occurs from glaucoma, we can never regain. We can never bring that back. And so the whole purpose of managing and treating glaucoma is to prevent further damage.
But you can't do anything about it. Can you find out about glaucoma before somebody gets it, or do you have to develop it?
So there are different risk factors for developing glaucoma. The best way to catch glaucoma early is to have an annual exam. Any eye doctor that is able to check you for glasses, they check the pressure, they look at the back of the nerve, and we use that information to assess someone's risk of having glaucoma. And so risk factors of glaucoma include family history. So if your parents have had glaucoma, that makes you more likely to have it. If your eye pressures are high, then it makes you more likely of developing or having glaucoma. Folks with high blood pressure and diabetes are more likely to develop glaucoma. African Americans are at higher risk than others to develop the glaucoma.
I've heard that.
Yeah. And the tricky part is some patients can have glaucoma even if their eye pressures are normal. So we used to think that if your eye pressure is high, then you have glaucoma. If your eye pressure is within the normal range, then there is no glaucoma. But what we now know is that some people's nerves are sensitive. And so it's possible to have a pressure in the normal range, normal being 10 to 20. It's possible to have your pressure in what we consider a normal range and still have slow degradation and damage to the optic nerve. And so we call that normal tension glaucoma. And so that's why it's important to have a dilated eye exam. It's important to have the optic nerve looked at and observed. And so just getting a pressure check in and of itself isn't enough to completely rule out glaucoma. You need to have the full eye exam.
You know, we raise our children and we worry about their teeth. We worry about cavities, and when I was a young boy, the cavities were more prevalent than they are today. And there were a lot of reasons for that. But we pay a lot of attention to dental checkups and make sure we don't attach, maybe we're doing it today, but I don't think so. But in years past, we didn't attach the same significance to an eye examination as we did a dental examination.
You know, there are mechanisms in place to try to catch pediatric eye disease. Babies are looked at when they're first born to make sure that they don't have cancer in the back of the eye. Generally, when children are born, in terms of glaucoma, the eye is much more elastic, and so pediatric glaucoma will manifest as something called buphthalmos, which means the eye is physically larger, it expands, it looks oversized. And so luckily, that happens, and that in glaucoma and pediatric, congenital glaucoma can be caught. But the tricky part about glaucoma is patients that have glaucoma do not know it because it is non-symptomatic, it's asymptomatic. You cannot feel the pressure go up. And so it's generally something that happens slowly over time, and it's sort of like blood pressure. Blood pressure might be normal, it might be high, but you can't feel it. And it's the same thing with the eye. The eye pressure can go up, you're not aware of it. And the real tricky part about glaucoma, and we call it the sneak thief of sight, is because it slowly degrades the peripheral vision. But the way that the visual system works is even if one eye is starting to lose vision over here, guess what? This eye can still see that area. And so your brain does not perceive that loss. And same thing, this eye could be losing vision on this side, but this eye can still see that area. And your brain summates the information. And so you can slowly be losing vision on the sides and be completely unaware of it. And that's why it's important for annual eye exams and screenings to make sure that this isn't happening unaware.
Is there an eye organization that is doing, I know the dental people are doing more about making the dangers of periodontal disease known. Why haven't eye doctors done the same thing about promoting the necessity to have annual eye examinations? I've never really seen anybody that really promotes that. Since I've been doing a lot of television, I have, but
well, there is legislation in place for annual screenings for high risk patients. For example, diabetes. Anyone that has diabetes. Their primary care doctors know that diabetes can lead to damage to the retina. Right. And so, they specifically ask their patients to make sure that they're getting their annual eye exams. And so, we do our best to try to educate folks. And if you have regular medical insurance, the medical insurance does cover medical eye exams. And so, people think, it's going to cost me a lot of money. I don't want to go see an eye doctor, but they may not realize that it's covered under medical insurance to have a medical eye exam. To see if they have any medical diseases like glaucoma or macular degeneration or cataracts.
Yeah. But since glaucoma affects the elderly so much, what are some of the things that you're doing with regards to the elderly about all the treatments? So we have a lot of new things that are coming out, a lot of ways that we can benefit senior citizens by better making them aware of this problem sooner. What are some of the things that you're doing now?
That's why I'm on this show, to help them be more aware.
But is there anything specifically, like one of the things here, what are some of the new and beneficial methods for treatment for glaucoma?
Once glaucoma has been diagnosed, then the goal of the treatment is to lower the pressure. And even in that one example I told you about, even if the pressure is already in the normal range, we still need to lower the pressure further until we get to a range that does not lead to damage to the optic nerve. And so the different methods that we can lower the pressure are drops, eye drops. Some people do great with eye drops. Some people have a hard time with the drops. They forget to put the drops in, they miss, it takes a certain level of dexterity. And so for folks that either cannot get the drops in, or maybe they're on drops, but the drops aren't enough to lower the pressure enough to get it to a safe range, other non-invasive ways to lower the eye pressure is something called SLT. SLT is an outpatient laser, and what that laser does, there's no incisions in the eye, it goes through the clear structure, that goes through the cornea, and this laser stimulates the natural drain, okay? And by stimulating the drain with the laser, it helps that drain open up, that helps fluid get out of the eye, and that decompresses the pressure, it lowers the pressure in the eye. And that laser usually takes about a minute and a half to perform. We do one eye at a time, 1 week apart for folks that have glaucoma in both eyes. And some of my patients, they don't need drops. They just have the laser. The laser usually lasts about 2.5 years on average. And once the laser starts to wear off, we can repeat that laser. So it's called selective laser trabeculoplasty, SLT. And so some patients, their glaucoma is treated just with the SLT. Some people are on drops and the SLT. And for some folks, maybe we've tried the SLT, we've tried the drops, and some people, those methods aren't enough. And then we have to progress to the next step, which is incisional surgery.
Are those laser treatments in the eye itself, or the around the eye or in the eye?
So there's an internal structure called the trabecular meshwork, and the trabecular meshwork is the site of highest resistance for flow leaving the eye. And so the pressure is regulated by how much fluid gets in the eye and how much fluid gets out the eye. And so drops lower the amount of fluid coming in, and that lowers pressure. The laser helps the fluid get out, which also lowers the pressure. And so, during this laser treatment, I use a little mirrored contact lens essentially, and I touch the surface of the eye, and the mirror allows me to see this structure called the trabecular meshwork, and then I can treat it. But I don't have to make any incisions in the eye. There's no risk for infection. The complication rate is quite low. Patients tolerate it very well, and a vast majority of the time, over 90% of the time, it's effective at lowering the pressure.
You talk about drops. I think of the drops that I was given, like for my cataract surgery, and all the drops I had to put in my eyes after the surgery. But then when we talk about drops, so many people go over and get over-the-counter stuff and buy it in drugstores, and they use the word drops also. Mm-hmm. What are there things that people can do and like they try to treat dry eyes? Can some of those things have adverse effects on problems of like glaucoma or anything like that? What should our viewers be concerned about when they hear you and me talking about something like this?
The over-the-counter drops are effective at helping with symptoms of dry eye by re-lubricating the cornea, and that can help the dryness and the irritation relating to the dryness and help your eye feel better. But the over-the-counter drops do not lower the eye pressure. They are not a treatment for glaucoma. And so you need a medicated drop prescribed by a physician to effectively lower the eye pressure and treat glaucoma.
So many people think you can go in and ask a pharmacist about certain things, and you can. Pharmacists are very knowledgeable people, but I can't imagine a pharmacist would tell somebody to use over-the-counter drops if they knew they had a medical condition in their eye.
They would probably be better served directing that patient to a physician.
To a physician, yeah. It's really interesting because there's so many, but when you say eye drops, the only other thing that you can do is like the selective laser treatment. Are there other things that people can do other than use drops to treat glaucoma?
So drops are an effective treatment. The laser is an effective treatment. There is a new class of surgery that we're starting to perform called MIGS, which stands for micro-invasive glaucoma surgery. And the neat thing about micro-invasive glaucoma surgery is through a micro-incision similar to the one that you had during your cataract surgery, through a 2-millimeter wound, I can go into the eye and I can help facilitate the outflow structures, meaning I can help lower the pressure long-term in the eye through a micro-incision, through a 2-millimeter wound. Some of these new surgical procedures, one of them is called an iStent. An iStent is the smallest FDA-approved structure, and it's a little hook device. It goes into the drain, and it helps open up the same structure, the trabecular meshwork. It helps bypass the trabecular meshwork so fluid can get past that structure more easily, help lower the pressure, and help treat glaucoma. And that's something that we can do at the time of cataract surgery. So patients don't have to wait until they have uncontrollable glaucoma to have a glaucoma procedure. They might have glaucoma and then their cataracts start to bother them. If they're already having cataract surgery, we're already making the 2-millimeter wound, we're already in the eye doing cataract surgery anyways, we can use that opportunity to implant this device called the iStent to help lower the pressure. The iStent is not the only microinvasive glaucoma surgery that I perform. There's also another device called the Hook dual blade, which I was actually part of the study to show how effective this device is. And what it does is instead of a little device that helps bypass the trabecular meshwork, This is a device that helps me remove the trabecular meshwork in about 25 to 30% of the eye. And so by removing the trabecular meshwork, you're removing the site of highest resistance for outflow, so it helps the fluid get out of the eye and lower the pressure. And so some of these devices are ways in which maybe glaucoma patients have been on, a drop for years and years and years and years. Their cataract surgery comes up. We do one of these procedures at the time of cataract surgery, and 70 to 75% of the time, they no longer need to use that glaucoma drop anymore. We're able to lower the pressure enough to get them off of topical medications for the glaucoma. One thing I do tell my patients, though, is even if the surgery is effective, even if we're able to get them off of their glaucoma drop, they still need to be followed in the future for glaucoma because they have controlled glaucoma, but we haven't taken that diagnosis away. They still need to be monitored because there's still a chance that in the future the glaucoma pressures may start to creep back up and we may need to reinstitute therapy.
You cannot completely get rid of glaucoma in an eye, can you?
We can control it.
Control. So,
sort of like blood pressure. If you have high blood pressure and you take a pill, then it might get your blood pressure under control. So even though your blood pressure isn't elevated, you still have the diagnosis of hypertension. You still need to be monitored and it still needs to be followed because you might develop resistance to the medicine. Maybe the blood pressure starts going up. It's the same thing with glaucoma. We can control the glaucoma in most cases, but you still need it to be monitored over time in case you develop resistance, or in the case of surgery, if we do a surgery and the glaucoma is controlled, you might develop scarring or something else, in the eye may change, and then we may need to take further steps to further control the glaucoma in the future.
When you talk about fluid on the eye and you got the eye with everything around the darn thing, with the cornea and the retina and all that stuff, where do these fluids in glaucoma, what are we concerned about? Why are we concerned, or where are we concerned in our eyeball itself about this disease called glaucoma? I don't understand that.
So it's all internal structures. There's an internal structure called the ciliary body that makes fluid. That fluid is inside of the eye, and it's completely unrelated to dry eye. Sometimes folks get confused when we're talking about, oh, your eye's dry, but you have too much fluid from glaucoma.
Okay.
The glaucoma is all inside of the eyeball. It has nothing to do with the outside. It has nothing to do with tears. It has nothing to do with dryness. The dryness and the tears is all on the outside of the eye. Glaucoma is fluid inside of the globe, inside of the eyeball. There's a structure that makes the fluid. That fluid tracks around and exits in a structure inside of the eye. And so the eye pressure inside is determined by how much fluid is made and how much fluid could exit. But it's all inside of the globe.
So that's why you want to drain the fluid off to lower the pressure from the inside of the eye.
That's correct. And so all these procedures that we're doing, the drops absorb into the eye and affect the internal structures. If we're going to do glaucoma surgery, majority of the time we're going inside of the eye and we're trying to increase the ability of the eye to get rid of the fluid. And so we're doing surgeries inside of the eye.
You did my cataract surgery. When you checked me, did you check me for glaucoma?
Absolutely. We check you for glaucoma before surgery. We check your pressures immediately following the surgery. And every time you go into the eye doctor, we check your pressure to make sure that you're not developing glaucoma. That's why they check the pressure.
Mm-hmm. Okay. When you did my eye surgery, when you did my cataract surgery, if I would have had glaucoma, the cataract surgery was more like on the surface of the eye, though.
It was inside of your eyeball.
Pardon?
The cataract surgery is inside of the eyeball. And so that's the reason why, it's not uncommon for your eye pressure to go up during the first 24 to 48 hours after cataract surgery. Because during the cataract surgery, and we'll talk about this later in the next segment, I use something called a viscoelastic. It's a clear jelly inside of the eye, and it keeps your eye inflated while I'm going in and out with the instruments. And then at the end of the surgery, I evacuate or I remove all that clear jelly. But it's clear, and they're little molecules, and so they can stick to different parts of the eye, and so all of that viscoelastic doesn't always come out. And so it can clog the drain and temporarily cause the pressure to go up. And so it's not uncommon immediately following surgery for the eye pressure to be up. Just because the eye pressure is up does not mean that it's glaucoma, because remember, the definition of glaucoma is damage to the optic nerve over time. And so if you have temporarily elevated eye pressure, it's common for me to put people following cataract surgery on a drop to lower the pressure. And technically it is a glaucoma drop, but they don't have glaucoma. They just have high pressure in their eye temporarily from the surgery. And so usually after a few days or a week, the pressure is back to normal, we can stop the drop.
It's amazing folks. We're going to do a show about cataract surgery, but this is sort of related to it because I'm always amazed when I talk to Dr. Darlington about how he was going to do the cataract surgery. You make it sound so simple that you can make a hole in the eyeball and then go inside and you put that gel inside the eye. Mm-hmm. And that's, what does that serve to dead it or to open it up?
It is thick, and so it's thick enough that when I make my micro incision, my 2-millimeter wound, if your eye is only full of fluid, which it is at the moment, which so is mine, and so when you make that micro incision, fluid is going to leak out of that micro incision, so the eye pressure will eventually go down to 0 or 1, and the eye will start to collapse. Well, that doesn't help the surgery at all. So I need the eye to be inflated when I'm doing the surgery, and so when I'm going in and out of your eye with instruments, I need the eye to stay inflated. So that's the purpose of this clear jelly. Is the viscoelastic will inflate the eye. It's thick enough so it won't leak out of the wound, so it just stays in the eye. And then that allows me to go in and out and perform the different procedures to get the cataract out and to get the new lens in while your eye stays inflated. And at the end, we take all that clear jelly out.
So when you find somebody that's got glaucoma and you try the laser treatment and you try all these other things, you can actually then go, what happens in the treatment for glaucoma when you go into the eye and you drain the fluid out? What do you do then, or what does the eye doctor do then to sort of prevent or to sort of control? How do you control the glaucoma?
So it's a system that is it's a process in the eye that's always happening. The eye is always making fluid. So if someone comes in with glaucoma and they have an elevated pressure, it's not as easy as, oh, I'm just going to make a little incision and drain that pressure out, because guess what? Within a few hours, the pressure is going to be back. The problem with glaucoma is the balance of fluid being made and fluid coming out is off. And so it doesn't cure glaucoma to just make a little incision and lower the pressure. That's temporary, and that will not long term control the glaucoma. And so that's why people that are on glaucoma drops have to take the drop every single day, because that lowers the amount of fluid being made in your eye every single day. And if we do a surgery, the surgery isn't to just lower the pressure momentarily. It's to change the balance, change the dynamic so that fluid can continuously leave the eye and keep the pressure controlled. And so, there's the microinvasive glaucoma surgery that I mentioned, which is a way to increase the drainage out of the eye. Okay. There's another microinvasive surgery that I can do called ECP. It's endocyclophotocoagulation. It's a laser that ablates the ciliary body, so it shuts down parts of the ciliary body, so less fluid is being made. And in some patients, I will do both. I will increase the outflow through, let's say, an eye stent or through a Cohook dual blade, and I'll do the ECP laser. And so I'm lowering the amount of fluid being made, and I'm helping the fluid that is made get out of the eye better. In some folks, that's not enough. We don't have enough effect using micro-invasive glaucoma surgeries. And so sometimes I need to do a more advanced procedure called a trabeculoplasty or a Ahmed tube shunt, which is I need to create a completely new drain. The drain in the eye isn't strong enough. We need to make a whole new drain for the eye, and that's also possible.
Okay, is that what you do when the topical treatments and stuff don't work as well?
Correct. Then we do more invasive glaucoma surgeries.
Is that a type of we're talking about some pretty complicated stuff here today. We're not, I'm asking you some questions. I'm flying by the seat of my pants with some of these questions, but they make sense because I've been through some of these eye procedures myself. Mm-hmm. So, but to the uneducated person, what should they, in view of everything we're talking about here, laser treatments, things that really following glaucoma and prevention of glaucoma, preventing glaucoma, what can we do to prevent glaucoma?
Well, the most important step is to get your annual eye exam, because we need to make sure that we're catching that glaucoma early, because remember what we talked about at the beginning, which is the damage from glaucoma is permanent, and so we want to catch it early so that we save as much vision as possible.
Okay.
And then, you know, as soon as that glaucoma is detected, as long as you keep your eye exams, you know, we can in a vast majority of cases prevent the glaucoma from causing loss of sight. And that's by, like we talked about, drops and or laser. There's the microinvasive surgeries. There's more you know, invasive procedures that we can do, but there's usually a surgery that we can do to get the glaucoma under control to prevent loss of vision.
You know, glaucoma, like you say, is a sneak thief. And Dr. Mendesi, when I first met him on a show, he talked about glaucoma too. Talked about the same thing, some of the same things you're talking about, but he talked about the optic nerves in the eye and how everything is tied back to the brain. Mm-hmm. And we just, having said all this, you're a young doctor, and we have doctors that have been treating and practicing for years. The last question I'd really like to ask you, Dr. Darlington, because since you are a doctor with access to a lot of the new procedures and everything, new thinking, the value of a second opinion.
I never discourage a second opinion. I think that second opinions are wonderful, especially because you know, you want to make sure that the treatment plan makes sense. You want to make sure that you're comfortable, you know, with the direction that you're going, especially if you're talking about having surgery in your eye. And so, you know, any of my patients, if they have any questions or concerns, I always recommend they get a second opinion. And if there are patients out there right now that want a second opinion, you know, I'm happy to see them and reassure them that, you know, sure, the treatment plan that, you know, that your surgeon is you know, discussing with you makes a lot of sense. And I see second opinion patients all the time, and I'm happy to you know, encourage that and reassure them that you know, that the recommendation that they're receiving is accurate.
But the other thing, and I would add, we got 6 seconds left. See your eye doctor on a regular basis. That's the best advice I think we could both give.
Absolutely.
Okay, thank you, Dr. Darlington, for being on the show today, and thank you, viewer, for watching. I hope you enjoyed our show. I'm Joe Steckler. Thank you for joining our program today. I'd like to remind you that our senior information line is available to you at 321-473-7770. There you can get help and direction that could be helpful for your specific situation or circumstances. The work of helping seniors is very important, but we can't do it alone. That is why our sponsors here in Brevard County are so important. I'd like to thank our many area sponsors, businesses and medical providers who support the mission of helping seniors that help us carry the cost of our media efforts. If you'd like to join us either as a business partner or simply donate as an individual, we would welcome your call at 321-473-7770. You are always welcome to visit our website at www.helpingseniorsofbrevard.org. Thanks so much for your help. It does make a difference.